I'd like to be very brief because we need the time for the discussion. You see the title of our first plenary is Big Data and Public Health Research, Will It Kill Epidemiology? You all know that we live in the era of big data. We produce massive quantities of information about ourselves, about our interaction with others through social media, for instance. Some of us have genetic sequences analyzed, there are health data out, and many other digital traces we leave. So the obvious question arises, could we use this data, this large-scale data, for research? As epidemiologists, we know how time-consuming, cumbersome, and costly it is to collect information from large samples of people. So much of the enthusiasm surrounding big data stems from the perception that it offers easy access to massive amounts of data, and thus we might replace some of the traditional epidemiology by analyzing big data, which is already there. However, the data that has been collected was not collected for research. And we have to ask critical questions about the validity of the information, how representative these people are where we have data from, and what type of biases might arise. Is it representative? Is it selection bias? So all the traditional methodological skills we have learned, we still have to ask these questions if we use big data for epidemiology. It's a very controversial discussion among the scientific public health community, and we therefore organized this plenary session also as a debate. Antoine Flahault will be the big data enthusiast, and Nino Künzli has the role of the critical epidemiologist. And we hope that this will stimulate the debate and that in the overall discussion at the end, we might find some more common grounds. We plan the plenary that Antoine starts with his presentation, 25 minutes. I will allow one or two technical questions to his talk, and then Nino will continue and we will have an overall discussion having both points of view heard in the presentation. So Antoine will be the first speaker. Antoine Flahault is, since this year, the new professor of public health at the University of Geneva, heading the Institute of Global Health. And I just can say Nino Künzli is the vice director of the Swiss Tropical and Public Health Institute and the head of the Department of Epidemiology and Public Health. So both experts, both epidemiologists, and I'm very much looking forward to their presentations. Antoine.
Buongiorno, signori, signora. That will be my last word in Italian. Maybe I can say grazie to la Università Della Svizzera, Italiana. Thank you, Luca, for this kind invitation in this fabulous location of Lugano, even when it rains. And yesterday it did not. Thank you also to the Swiss School of Public Health Plus, and welcome to all the doctoral and MPH students here attending this summer school. Thank you, Charlotte, for this kind invitation to give us the opportunity to discuss about this very important topic of big data. And I would like to thank also the Swiss TPH and the SDC for their support to this so important common course in Switzerland. And thanks to Nino to be the critical epidemiologist here. So we have chosen some very provocative title in saying that, will it kill epidemiology? And you may see that big data may be a threat or an opportunity with regard with epidemiology. We will, first of all, try to define what is big data. Maybe a lot of you know these buzzwords of big data, maybe not all of you, and I want to spend these 4 next slides to define what are big data. Big data are usually defined by the fact that they are big, because of the volume, because we are surrounded by a lot of data produced by Twitter here, by social networks, produced by mobile phone, produced by hospitals, produced by insurance company, produced by our smartphone, and so on. And what is true is that some other sectors, such as finance, marketing, use this data for their own purposes. And what we have to think and also to look after is what are their potential for use in the health sector. The second characteristics of big data is velocity. The fact that these data are not collected as we collect data for any epidemiologic studies for a defined period of time, and when you have collected all of them, you can start your analysis. Maybe you can just clean your data file, but after you can start your analysis on a specific time period, and all your conclusion interpretation will really address this time period, this population, and so on. Big data are usually an ongoing collection of data, and you cannot stop it. You have a lot of data coming even after your analysis is performed. The third characteristic is the variety of sources of data. When you have when you conduct a survey, when you conduct any epidemiological studies, usually you define and design a questionnaire, and you have a format of your data. Some data are maybe numeric data, some may be characters, why not? Chain of characters, but you define them. Sometimes you have thesaurus and codage and a lot of work ahead before collecting them, which helps you for analyzing them thereafter, and also for cleaning them thereafter. In the big data, usually you have a lot of, a tweet is not formatted except in length. A blog is not formatted even in length. Any hospital or insurance data may have different format, even within the same city when you have various hospitals belonging to the same institution. So you may imagine how difficult you will have to face the problem of variety. And of course, I will say the fourth characteristic of big data is to bet that it will bring some value. It's not only data, it's information that will provide you some information, why not some knowledge. Big data, as I said, is a buzzword, but in fact, many epidemiologists have already used big data much before the terms big data were used. I mean, when we are talking about genomics, of course, genomics are generating big data. Many studies which have been performed even a decade ago were big data, for sure. What I wanted to point is a few examples of what we are calling today clearly big data, and how that can be of value, of use. And there was an initiative launched by UC, University of California, Davis, and the FDA and also the CDC, trying to say we cannot wait so long when we have a foodborne disease outbreak, which is due to an unknown pathogen. You may remember in Germany a few years ago there was a Escherichia coli severe outbreak with dozens of deaths, and there was a lag time between the identification of the strain and the real knowledge of the source of the strain. It was the first culprit was Spanish cucumber. They were not at all the culprit. The strain did not come from Spain nor from Portugal, but came from Middle East and from Egypt. So by real analysis of the genomic pattern of this foodborne pathogen, it would have been much easier to determine that this strain was definitely not coming from Spain, but from another origin, geographical origin. And that's the aim of this 100K foodborne pathogen genome project. They want to collect 100,000 pathogen genome sequence, and when you have, and that will be an open database, and when you have any outbreak with a new strain, it's easy to sequence it, and when you have the sequence, you can compare it, and you can have some clues about the origin of this strain. It is very important in a period of time where all the consumptions are globalized, and you never know when you eat some peanuts or some dry tomatoes from where they were processed and from where they come. If we keep sticking on the genetic aspects of the big data, which is a real avenue of big data, there are also some attempts currently available on the net. It's not the future I'm talking about today. On screening for genetic disease, there's this website, Künzli, where the promoter says that every adult in a reproductive age should consider the Künzli test before pregnancy. I'm not sure it is exact, but what is sure is that they provide 150 tests in a single sheet, and it is already reimbursed by some health maintenance organization in the USA. So today we are facing this kind of new tools which use large amount of data and which are continuing improving. In another topic, which is a topic I know a little better, the monitoring of emerging infectious disease, we are also benefiting from new big data. We have satellites above our heads which collect data almost free of access, I will say, which are almost never used for any epidemiologic purpose, but which could bring some interesting clues for understanding emerging outbreak of infectious disease. For instance, that was in May 2004, when in Lamu and Mombasa, which is in Kenya, really close to the Comoros Islands, Mayotte in France, and also Réunion Islands, the Indian Ocean Islands, Madagascar, and that was this map is a heat wave with also a period of drought in this part of the world, which has been associated to an outbreak of chikungunya disease. Chikungunya is a vector-borne disease. The vector needs some water of course, because it's a mosquito, but this kind of mosquito usually is very domestic, is very close to inhabitants, where the inhabitants collect the water in jars close to their home for a period of time because of the drought, because of the heat wave. So because of the drought and the heat waves, they collected more water and store it for a longer period of time close to their houses, and that was what the entomologists assume, maybe one of the reasons why this outbreak emerged in the Indian Ocean at that time of the year. I talk about Twitter or Google. Yes, Google has been used and is currently used for monitoring influenza. Of course, it's not a collection of data. It's not a heavy setup of sentinel general practitioners or hospitals trying to collect data on flu with a rigorous format of data. No, it's just when people today have flu, what do? They go to the Google and they search for fever, paracetamol, influenza, flu. These kind of words are some indicators of the flu. And if you plot these indicators on a time series, you have something which is very close to the red curve, which is the CDC surveillance system. Close, better than close, a little earlier, because the CDC collect data from general practitioners, but the Google collect the search items from the people a little before, 1 or 2 weeks before they go to their doctors. So what happens in 2013, January, in New York City, is that the Google was 2 weeks ahead of time. It's not visible that it's 2 weeks ahead, but believe me, yeah. And 2 weeks before the CDC said something, Google said, oh, we are facing a large outbreak in New York City. Also, the people went to their, and people were maybe afraid or maybe interested in, and they went massively to their computer and asked for flu. And so there were queues in near the pharmacies because they wanted to have some vaccines and some Tamiflu and other drugs. And so there was something which was more than real. And Google did not catch it. So Google said, no, it is increasing. Oh, yes, the signal was increasing. But when the CDC came 2 weeks after, they were able to say no, there was no specific amount of cases in New York City this year at this time of the year. It was a normal seasonal flu. But Google thought it was huge epidemic, even seasonal, at this time of the year in New York City. So, of course, these tools are not yet mature, but that does not discard the very interesting impact of these tools for public health surveillance. For instance, today at the CDC, no one in charge of influenza surveillance doesn't look to Google flu trends. It is free available on the website. And there are some attempts also to use the Twitter, because when you have flu, you tweet that I have flu, I am stuck in my bed. These kind of words you can, and this kind of little messages, you can try to exploit them and try to have some insight and some information for the fact that there is something happening in your county, in your country, in your region. We have used in France, when I was at INSERM in charge of the sentinel surveillance of influenza, we have used another set of data, which are also big data, which are drug sales. You know, if I say that people are really searching for paracetamols and Tamiflu or these kind of drugs, we can imagine that a couple of drugs probably are good indicators of influenza. Well, it is interesting because you don't need to collect this data for this purpose. You have this data. Maybe not you, but there are some data brokers, IMS or these kind of companies, which sell this data to pharmaceutical industry, but you may have an access, or you may buy them, but you may also have an access. We had an access for free to use this data for epidemiological purposes. And we published this work where we try to forecast with some mathematical models the trends of flu just because of the drug sales. And since we had a sentinel surveillance, it was possible, like the CDC for Google, to see if there was some good prediction of the drug sales consumptions as indicators of influenza and the influenza as observed. So, and that fit quite well. Probably these tools are prone to biases. Probably you may have also some kind of media booming just because you advertise too much. Maybe the people will go to the pharmacy even if they don't have the flu, and that may perturbate these signals. But anyway, that is the kind of signals we probably cannot neglect today. If we are talking about drug safety, pharmacovigilance, it is so difficult today to face a number of scandals, affairs, and because of the time delay, we are taking in recognizing, in identification of new adverse event to drugs. Sometimes years are spent before a new adverse reaction is clearly identified and the causal relationship is clearly demonstrated. There are some tools used on the internet, because if you have an adverse event, you go to the internet and you search about this adverse event, even if it, and maybe particularly if it is not mentioned in the fact sheet. So you go to the internet. If we know that you have this drug, so it needs some voluntary participation of the people who have these new drugs, and we can follow their search on Google or on Yahoo. There was also a publication which was interesting from Camille. Camille is a researcher from Harvard School of Medicine, and he published in Science Translational Medicine something where he studied the drug profiles of which are completely publicly available, and he compared that with some patterns of adverse drug reactions. He studied that in the learning sample, 800 drugs and 852 adverse drug reactions, and after he launched this model, after this learning phase, to a validation sample, exactly if that was a prospective sample, but that was in fact retrospective, on data from 2006 to 2010, and he obtained a very good prediction of 7 out of the 8 major adverse drug reactions which occurred in this period in the US. So what they said is, we have now the potential, thanks to statistical tools, data mining tools, to really have some clues, some prediction of what could be an adverse drug reaction. They don't say you don't need any pharmacovigilance experts, you don't need physicians or pharmacists to really assess the causality and to really explore these issues of pharmacovigilance, but we may point out where you have to work on and when you have to maybe concentrate your efforts, because there are some values in terms of prediction by using these models. So if I can summarize, big data, we can maybe have several different aspects. What is called today bioinformatics is what regards genomics and genetics. It's proteomics and this kind of omics I mentioned in my early slides. So this is an avenue where we have a lot of bioinformaticians processing this data, and we may have some new information derived from this data, as I showed you, even in public health, not only in fundamental science. The second avenue is the so-called open data, which are various files of data from hospitals, from electronic medical records, so even from ambulatory medicine, from the medical insurance, you have the reimbursement, all this data, and from data brokers like the drugs I mentioned. So we could use also this kind of data for many public health purposes. We have the search engines, the websites, the social networks, Google, Twitter, and all I mentioned, but also I did not mention too many of them, but there are more and more apps and mobiles which does not collect, they don't collect data for any specific purpose, but they collect data anyway, and we don't use them for any purpose in epidemiology, and they probably will be of interest also. And there is a fourth avenue, which is also of great interest regarding environmental health. I mentioned the remote sensing data, the so-called satellites data for climate and weather forecast, but also for air pollution. We have a lot of data from air pollution, weather, climate change, vegetation anomalies, and so on. What I would like to conclude with is that there are some challenges and threats, not only on epidemiology. Of course, what is interesting is that thanks to these big data analysis, we will probably help improving the quality and the efficiency of the health care system, because we will have more data, more in larger scale, maybe more timely recorded. We will face probably ethical issues. I mentioned some record linkage which are needed for using big data, and that may raise some confidentiality and privacy issues, not only in health, but particularly in this sensitive technical issue. There are some data quality issues, because these data are for various quality, various formats, and so on, so there are some huge data quality issues. It will create some new jobs, definitely. We know that for bioinformatics, but it will be true also for data mining and for public health purpose. There is some international competitions, and we cannot be a part of this competition. We have skills, we have a lot of opportunities in Switzerland to invest these avenues, and we will probably have to go into. Now, will it kill or not epidemiology? There is some potential that there is a kind of another paradigm with big data. We did not discuss this point too much, but big data implies that you are in a situation of observation. You hope that from the data you will have some hypothesis. You know, the traditional paradigm is I have some hypothesis. Is the drug better than the other one or the placebo? And I will set up a protocol. With the protocol, I will set up and design a real data collection with maybe randomization or not, I don't know. And when I have collected my data, I will process the data, clean them, analyze them, and interpret them, and I will answer to my question, to my hypothesis. There is an hypothesis and a conclusion. With the big data, it's not like that. I have no hypothesis. Maybe a new adverse drug reaction will come. I have never tried to think about it, because it's just a search which appears on my screen, which is surprisingly associated with this drug. So there is a reverse paradigm, which is a threat, a danger, because it may raise a lot of false alarms, false alert. But maybe that will be a way which will, in some way, discard or diminish the interest of epidemiology, of the classical epidemiological methods. We will maybe talk about some examples in the discussion where clearly I think that big data may be an easier way, and maybe also a more rapid way to answer to some problematic questions. So thank you for your attention, and Nino will take over.
Well, thank you very much, Charlotte, for the introduction. And Antoine, thank you very much for emphasizing the big data revolution that is going on. As an epidemiologist in training myself, so let me defend now what I call rigorous and thick epidemiology. And I have to say, definitions of big and thick are not yet universally clear. So let me present my definition for the sake of this debate here, my specification for the distinction of the two, relevant in the context of the public health research, is that big data are certainly large, but while thick data may be large, and we may come back to that, the focus is more on quality, content, context, rather than quantity. As we will see, thick data are certainly not opportunistic, but collected or used under very specified principles. In particular, I do not restrict the definition of thick data to mean qualitative data only. There is a literature out on some people using it strictly in that sense. So while I'm not saying that big data may not share some of these features here, my point is that these features are essential characteristics underlying thick data epidemiology. Data are hypothesis-driven. Data collection follows defined plans, is based on well-selected people. Most important is the concept of standardized collection of data, which must include subjective, objective, data, quantitative, qualitative data, blood samples, DNA, material, etc. So how can I convince you from the need of thick data? I thought I will not present big theoretical concepts, but just a few examples. And my underlying question for all those examples is, could we address those issues with big data only research? And I will conclude as an outlook, actually, a specific focus also on needs in Switzerland. Let me use examples within those domains here, which are key domains in public health, most relevant for public health, and of course, on top of my list is poverty. The prime cause for poor health is poverty, socioeconomic deprivation, low education. So this is true both on the macro level, comparing between countries, but also within countries, comparing between people. So let me use one example, which is based on the in-depth study, the International Network for the Demographic Evaluation of Populations and Their Health. In-depth is an umbrella organization running an impressive, thick, and big data initiative in more than 40 countries around the globe, in particular in Asia and Africa. In-depth demographic health surveillance systems established in those communities, they visit all households of the target population up to 3 times per year, year after year. The full coverage surveys collect basic demographic data piggybacked with additional targeted information as needed to assess specific questions. So in this example, based on 8 in-depth sites that collaborated with more than 40,000 subjects, adult subjects, this is just one example how the data from 8 sites were used to investigate, for example, inequalities in health and ask the question about the determinants. Substantial gender differences were observed with the greatest levels of inequalities in Bangladesh. The analysis showed considerable variation in how socioeconomic characteristics explained the gaps in self-reported health. It showed, for example, that pain and sleep-related issues would contribute to health in all regions, but there were large differences. Differences in household socioeconomic levels, age, education, marital status, and living arrangement were explaining a lot of inequalities in many regions, but not in all. They were, for example, irrelevant in Bangladesh. So the study lays a foundation for evidence-based approaches to resource allocation and to developing health promotion programs for older men and women in these settings. So big opportunistic data will not get to that point. And actually, let me focus most importantly now on a very complex mental disorder, which should reveal how important it is that we have thick data. Self-harm, suicide, as an example, suicide as one extreme form and consequence, in fact, of mental problems. It is one of the top causes of the years of life lost. In many countries, in Switzerland, self-harm ranks as number 4 for years of life lost. Suicide rates increased by 32% globally in the last 20 years. It is particularly important in the young. 5% of all deaths in those aged 15 to 50 are actually related to suicide. And China and India account for 85% of all suicides. So this review here, they looked into 36 thick data research on suicide in India. Key determinants of suicide could be identified as poverty. Again, we're back to poverty, mental illness, and interpersonal difficulties. It is very clear that such research needs thick data. In fact, one conclusion of the review is that if you don't go out with qualitative research, you underestimate, in fact, the suicide rates by about a factor of 10. So let me move to another perspective, chronic non-communicable diseases. For the chronic non-communicable diseases, or the NCDs, let me take one example. It's the leading non-communicable disease in children, which is asthma. Asthma is characterized by a pathologic reactivity of the airways, which is leading to the acute narrowing of the airways, with the consequence of having severe attacks of dyspnea, sometimes requiring hospitalization and sometimes even leading to death. It heavily affects quality of life of entire families, not only of the child. We have in fact estimated in a recent study that the annual costs of an asthma child for the family is about $4,000 per year, and this is based on a Californian health system setting. I choose asthma to emphasize the key limitation of opportunistic big data, which I would even say they are jeopardizing the advancement of knowledge. So look at this. Asthma is like most, if not all, NCDs. It is a very complex multifactorial disease. In fact, it is not just one disease. So you see here these bubbles, 4 different types of asthma. And research must be based on data that capture the phenotypes of this disease. Big data are driven by questionnaires and genetics. And combining those two, you will never enlighten these patterns. It is not sufficient to just combine genetic and questionnaires. Clearly not. And in fact, it would never explain what we start to enlighten and understand in this complex disease. There is not just one type of asthma. And this study made very valuable contributions and attempts to classify asthma by various phenotypes. And in fact, they have shown that the genotypes are also related to the different phenotypes. So the classic big data approach to asthma has shown for many years genetic patterns which we now understand relate only to the allergic type of asthma, which is just one of the phenotypes. So look at this. Thick data means that you collect information on asthma activity, on allergy status, on the age of onset, on bronchial reactivity. Where would you ever get that in a big data Google type of setting? Lung function, you measure something, objective measurements. Good. Let me move out from NCDs to infectious disease. An example using neglected tropical diseases, which is as well actually a focal area of the Swiss SSPH research, like asthma. Charlotte Braun-Fahrländer, he was a leader in the allergy and asthma research in the last 20 or 30 years, in fact. So along with HIV/AIDS, tuberculosis and anemia, malaria and helminths, or the worms, are the main causes of years lived with disability in the sub-Saharan Africa region. So to achieve effective and sustainable control of these wormy diseases, with more than 1 billion people affected globally, and with very, very high rates of reinfection after treatment, a deeper understanding of the social ecological systems governing this endemicity of these diseases is really needed. So we need strategies beyond preventive chemotherapy to tackle the multiple causes of infection and of reinfection on these wormy diseases. So in fact, this study is a study on thick data again. It was conducted in 92 schools all across Côte d'Ivoire. School children provided blood samples for the detection of Plasmodium, a malaria infection, stool samples for diagnosis of soil-transmitted helminths, the worms, and schistosoma infections, and urine samples. Imagine this. Urine samples, stool samples. Could you ever imagine to get this information through big data, Google-based approaches? Forget it. Or on an analysis using mobile phone data? Forget it. We need cumbersome, field-based, classic, dirty hands epidemiology. We have to have people going out, talk to people, touch people, and investigate on them. So, of course, as you see here, combined infections were very common, and actually the study will find has provided the rationale to combine control interventions that would simultaneously aim at the worms and at the malaria in this setting. So we should be really concerned if funds are moving toward big data only, as it will cut funds away to collect targeted, thick data to improve public health. Well, let me move to an environmental perspective. And this is a historic example. It's a fascinating story, in fact, and it shows us how wrong science can go if we do not use the right methods. I use an example based on ecologic data, meaning this person has just associated the radon levels in the environment, in the underground, with the mortality rates in communities. So each dot here is a community. There is a whole cluster of publications out in the 70s, 80s, and 90s of the last century, mostly around the physicist Bernard Cohen, who used what we would probably call today big data. Had he expanded it on the global scale, which today would actually be possible. So he took these radon concentrations and associated them with the cancer rates, and look what he got. He got this red line, this negative association. So he observed that many times this protective association of radon, which is a carcinogen, which we do know is causing lung cancer. He has built a whole theory about hormesis, the idea of generally favorable biologic effects of low-dose exposures. He has never accepted, and I think he has not accepted until his death in this century, that causal inference requires thick data that are collected on individuals, not just aggregations of big data, analyzed on aggregation. So we need analysis based on individuals, individual data, taking into account other factors collected on those individuals, like, for example, smoking. Of course, if you go to the New England Journal of Medicine article of Messerly, this one here, it was very clear that this is just a joke, that he just wanted to show that Switzerland ranks highest in terms of the Nobel laureates, and that this correlates with the chocolate consumption is, of course, a joke. Although I would actually very much like if chocolate would also improve my brain capacity, but that's not what Messerly was saying here. It's just about the Nobel laureates rates from Switzerland. But Cohen, in terms of radon, he was very adamant. He was really literally serious about his hypothesis. And it was only through thick data that this could have been shown that he is wrong. So there are correct, thick data, longitudinal studies showing this nice linear dose response between radon and lung cancer rates. So the higher radon in your home, the higher are the rates of mortality due to lung cancer. And in fact, what the thick data approach was also revealing is this very strong interaction between smoking and radon. So people who smoke, they amplify the risk that is related to radon. So let me move to last example, which is more a perspective on lifestyles. Physical activity is, of course, an important aspect and a crucial determinant of overweight and obesity, which in turn becomes the most important driver of non-communicable diseases on a global scale. To understand the role of physical activity in the obesity epidemic and the causes of the lack of activity, we need well-designed studies, again with people. So you may look at this study, which was done in Swiss children by the group of Charlotte Braun, and they compared the Swiss data with European countries. The comparison has shown that the prevalence of overweight is lowest in the Swiss schools compared to the other European sites participating in this European project Energy. But there was no difference in the dietarian habits with regard to sugar drinks and breakfast. However, the activity patterns were significantly different, with higher activities in Swiss children and less sedentary time spent on TV or on computer screens. So the data revealed important differences also within Switzerland, with the poor and the non-natives having the least favorable habits. So look at the list of information collected in this study. And you may agree with me, such information is thick, and you will never just get that out from Google. Diet, a food frequency questionnaire, sedentary activity, sleeping questionnaires, etc. Of course, being in Lugano, I owe you a very last example of thick data epidemiology. Lugano, since 1991, is part of the only Swiss national population-based cohort study that we are running. 3 times already the same people have participated, and Nicole Probst has just received the next grant to follow up them for the 4th time next year. So this is very thick data collected originally for the hypothesis to investigate the long-term effects of air pollution. So SAPALDIA stands for Swiss Study on Air Pollution and Lung and Cardiovascular Disease in Adults. But of course, it's much more than air pollution. So look at this. This is just an example how thick data collection looks. You really go out to these people. Some 1,000 people from Lugano are participants. They have come back to the center every 10 years, providing, for example, measurements of lung function. You don't get that in the Google nor on the mobile phones. You have to do it, and you look at here. This is the thick data type of research paradigm of the SAPALDIA 3 study, where it is about the interrelations of lifestyle, of nutrition, of socio-demographic factors, gender, genetics, health, conditions. So if you look a little bit down on this diagram here, there's no way to investigate the causes of lung development without thick data. And this is why SAPALDIA has been clearly designed to investigate very clear and strong hypotheses. So we do need huge data. Of course, I'm not saying that we don't need big data, but those big data must be first and foremost thick, non-opportunistic, and must include objective measurements, functional measurements, qualitative data, biologic material, and then I would say we can move forward with public health-related science. And of course, yes, there are examples of thick and big data, and that's what I think we should really consider and discuss. So these are examples of population-based thick data collected on very huge samples. Look at the Swedish study. Sweden and Switzerland has a comparable size. 500,000 subjects are participating in this study. Very big, very thick. We don't have a thick mega cohort in Switzerland at this point in time. But I would like to conclude, in fact, with the call for going in that direction. In fact, Swiss TPH has very much taken the initiative with Nicole Probst and others to come to the point that Switzerland will move into funding a very large mega cohort of something like 100,000 people. We started with an international workshop a couple of years ago. The Swiss National Science Foundation has raised a lot of interest. A lot of discussions have gone on. And actually, the SNF has launched a call, which is now running, so-called call for supporting biobanks. And in that call, the patient-based cohorts are coordinated by Vincent Moser from CHUV in Lausanne, and the population-based approach by Nicole Probst at our institute. So this is an initiative toward large-scale national mega cohort, but there is still a long way to go, I have to say, and we should really be clear also as epidemiologists to spread the message why we want to do that. I'm here to enthusiastically defend the notion of non-opportunistic data, thick data platforms to tackle questions and hypothesis-driven research. We do need those mega cohort approaches also in Switzerland to understand the changes, the trends and its causes, the health systems factors in Switzerland and its determinants in the Swiss context, in our context of societal changes as well. So we should not just rely on German or Swedish or UK-based studies. And in fact, as you see here, it's also strengthening the Swiss research generation, future generation. So I think it is very important that we unite all together in calling for such big and thick approaches and warn those funders who are enthusiastic to instead invest only in big data because they're considered to be cheaper, easier, fancier, funnier. Of course, it's very nice to work with Google. So no, my message is really we need carefully planned epidemiological studies. And I would like to thank you for your attention, and I would like to welcome you on a symposium which goes very much in that direction, that we have our fall symposium in December in Basel. Thank you very much.
Thank you very much, Nino, also for this enthusiastic talk to or call for thick and big data. I would start with the question to the audience. Do you want to ask questions or comment. Yes, I think you.
Hi, very, very interesting talks. Thanks, first of all. I believe that if we, let's say, fight big data on the ground that the ground that they are not so deep and their quality is not so high, I think that this is a battle or a war that we are going to lose. Because in the future, I'm pretty sure the quality of big data is going to improve, and also the deepness of this data is gonna improve. I think that the two types of data can develop together, because big data represent an opportunity to find new research questions and a way also to look for some initial effect that might be instead affected by the usual problem of observational data, so selection, confounding factors, and starting maybe from some potential research question that comes from big data, we can run new and precise, what you call thick data that can go behind this kind of problems that affect probably and will always affect big data that are selection and confounding factors. So I think big data may be a starting point for finding new research questions that can be analyzed better with thick data.
Klaus Schipper representing GeoHit Corporation under the Horizon 2020, looking for big data initiatives. Throughout the past 3 years, we now have come to the conclusion that we probably will have to divide Europe into countries with high quality but low data quality, and high quality in the healthcare and high data quality. So coming from Denmark now, having all patients since 2007, 4.5 million, with all the patient records and all laboratory data, we still do not consider this here at the Computing Science as big data. But I loved your two talks, and I think you are the people who are deciding on the Swiss future. Where would you like to see Switzerland in the future? In Denmark, we have opened up for all patients. So patient rights are neglected, and the state is basically claiming all your healthcare data in all areas. But I think Switzerland has a unique opportunity now, because you're considered from everybody as a place where it's safe to store data. But I really would love to see Switzerland also in the EU project with their own position, and also an own position on sick data, keeping the privacy along. Comment to Google, we tried to work with them on several areas in several countries. There is one point we never agree on, and that is data privacy. They simply do not accept legal national data privacy laws in any country I've met them. So I think as a physician, for me, this is a point I do not want to go to. But I would love to see and hear your comments on where you want to have Switzerland in the future.
You answer, and Marcel, you want to directly?
If I
Yeah.
add a point, then you can take this up in the answer. Thank you very much. I think this is very stimulating. But exactly in the way that you have looked into the future, and the fact that whatever Google does or whoever does, this is a reality. And also in view of that, those information or the low quality information, or the information that may drive public opinion more than, for instance, the designed epidemiological studies as we hear, how we can reconcile that. We have to live with this reality. And I would like to hear from Antoine and Nino how we can actually make a step. I think it is this group here that needs to see what are the compromises possible and how can we bring the elements together. Tomorrow we discuss how can we influence policy and decision making with data. And I tell you, a Google approach becomes stronger and stronger in this effort. So we must actually more look on how we create the best interfaces and how we reconcile in order not to have these policy decision-making processes going seriously off track. And everybody is just looking at Google flu trends and whatever and creates. Then comes the Google Ebola trend and the Google I don't know what. And at the end, we are actually driven by this.
Okay, so I think a good collection of questions to answer.
Well, let me pick up the question of how to continue for Switzerland. As you may know, we are of course very jealous since a long time about the situation in Scandinavia. You have a completely different paradigm and framework. You should not forget in Switzerland we have 26 healthcare systems. We have not resolved how the confidentiality issue, informed consent, data protection should be resolved. So talking about the policy framework, I think this is one strategy one has to really work together to make sure that the data protection, let's say the fanatics of data protection don't take overhand in a way that we will be unable to do serious sick type of research and ultimately rely exclusively on those frenzy systems where people just agree to share everything of their life, some people, but others not. So I think this is a key story to follow up in the policy-making world, to make clear that we have even the right to have an identification number the way you do have in Denmark. How to do it in Switzerland? Well, I think somehow the country has a tradition of pragmatic solutions. I mentioned this biobank initiative, which for your standards you would consider to be ridiculously small, but it is a first step. And actually Vincent Moser in Geneva, what he did, he simply started to have an identification of all patients who go through Geneva. So they are creating this patient-based, which is fantastic and important. So having patient-based cohort, there is a move just happening by doing it. To do the same on the population-based is much trickier. And we are in discussion locally with local universities to have also a bit the approach to just start with an element. And in fact, the Sapaldia study would have a whole palette of tools how to just embark on it. So I'm optimistic that it might happen, but there is a huge policy side to clarify it, and of course the financial side, because it looks like we need very big money. And yes, they have actually applied for an infrastructure grant of 100 million to pave a bit the path. So it is hard to say where we move, and maybe 1 to 3 years from now, I hope we are on track. But it's far less simple than what you do in Scandinavia, given your tradition. I don't know how you see that. You have actually a French tradition, which is again very different.
Yes. I appreciate Nino's positivism on thick data, but I would like to remind you some sad stories, I will say, regarding thick data. Mammography. It's a huge controversy nowadays, and mammography has been subject to a series of randomized trials, properly done, with more than 300,000 women enrolled in. So thick data with the most valuable methodology has been applied for trying to solve definitely a problem, which is mammography an effective tool for early screening of breast cancer? And nowadays we don't have the answer. I am forecasting or foreseeing that for electronic cigarettes, we would face exactly the same problem if we would embrace the thick data approach. So I'm not completely sure about some of the comments I've heard that could be a starting point, a useful starting point completed with thick data, or we have to combine both approaches. Maybe we have sometimes to use one approach, maybe not the other one. For electronic cigarettes, if you conduct cohorts, appropriate cohorts, even randomized cohorts, it's not possible to randomize. You will smoke, you will vape. I cannot imagine that. So you will have to take a non-randomized approach. And you will say, we will follow vapers, I mean electronic cigarette users, for a couple of years, long time of years, because we need to wait for their lung cancer. Or so in 10 years, in 15 years, we will conclude, but in 15 years, the devices will have changed. And they will say, oh, it's not randomized, the device has changes. I'm not convinced by your conclusions. What I'm saying is maybe in this kind of questions, the big data, if they are not so well designed, if they have not collected very dirty hand data with field research, but if they are involving millions of citizens from Sweden, France, the UK, Germany, Switzerland, the US, New Zealand, I don't know, and if they converge to the same conclusion, you may be more convinced by a unique cohort, very well designed, with a device which is 10 years old. So I'm not so sure today that both approaches may be combined, that compromise may be done with both approaches for all the questions. What I'm convinced, of course, is that there may be some room for one approach and some room from the other one. And that will not be so easy to know which is dedicated to what question.
Antoine, let me maybe pick up the mammography example. I think if you want to explain us how you would get at least at the point where we are in terms of knowledge without all the trials that we have on mammography, but using just a big data approach, I would be very interested. I would use the mammography actually in another way. It is very clear that due to the thick data approach, we do know a lot. People are just not agreeing exactly how to apply that in the health systems. So because we do know a lot based on thick data, not on big data, well, big and thick, we do know the risks of making a mammography. We do know the false positive rates, the false negatives one. So we know specificity and all that. So that helps a lot to calculate the benefit, the economic one, and to make a decision either based on people's perception of risk or on money. So this is a very solid basis. And in fact, I think I would use the mammography example to bring all those constituencies on board for the move toward big and thick data, all those working in the personalized medicine. Because, of course, mammography is an element of personalizing prevention. Personalized medicine needs big and thick data to actually clarify what type of advice will lead to what type of decisions and outcomes. So we need to know what a marker for whatever really means, what the false positive rates are, the false negatives. We need to know what people do that get an information about a marker of whatever risk, because they will run maybe to an expert, maybe to 7 experts who someone has to pay. So I think there are huge consequences of this paradigm of personalized medicine, that if we do not have the big and rich and thick data, we will have very big difficulties to really answer based on evidence and make decisions based on evidence.
I would like to come back to Marcel's suggestion, because I think we can easily see the advantages and the disadvantages. You can always argue about, non-complete evidence from traditional epidemiology, but I would like to know from both of you where you see a serious application for big data, because if we have to discuss with politicians, the trade-off will always be money. So we will have the conflict that either they finance big and thick, which is expensive, or they might be more tempted to say that's too expensive, could we do it cheaper? And where would you see possibilities, I say, for this opportunistic, cheaper approach?
If I can say something here, I think you ask a key point. In fact, many of epidemiological data are not so thick. I mean, when you combine the data with biological samples, with genomic samples, with environmental data, with contextual social determinants, you collect something which is what you called thick data, and what is thick data. So all your examples were really good examples of what is the good epidemiology. What I'm thinking is, in many occasions, public health is producing really poor data. And even many registries are isolated. not combined, the data are just phenotypes, not combined with biological samples or with genomic samples. So we found some initiatives which are rather poorly defined. I was myself in France in a very good research unit in charge of a sentinel system, and we collected poor data. I mean poor quality data. And we spent a lot of effort to collect them. That was for flu, but we did not had any samples, virological samples. We did not had any confirmations of the diagnosis of flu, but just because of the impressive peak we obtained in winter, we were in the possibility to match that with the Pasteur Institute samples and say it is flu, it is influenza. But when you see that, I think that the drug sales or the Google flu trends could be maybe as well of quality which is almost similar or maybe sometimes better in terms of statistical power than what we collected. So I'm just addressing my experience where we had these dirty hands because it was a cumbersome, very difficult, expensive work, and at the end of the day, I'm not so sure that these data were so sick.
Well, my opinion on that is I think, of course, at the end of the day, we should utilize both approaches. But I think the pillar on where all this should stand, particularly under the perspective of the non-communicable diseases, which are a global threat all over, I think having systems like in Denmark, where you have maybe not the total population, but where you have a very large cohort that is committed over very long-term time to contribute to progress in science, in providing standardized information, I think we should get to that point. And then, of course, we should be very smart and bring in and combine with all kinds of registry data, which should have good quality. We should bring in a lot of existing survey data. And in fact, Switzerland is doing that also in the context of the Swiss National Cohort, which is just based on this available type of data, which is a good step in the right direction. But I just think we should not leave out the absolute need to have objective, to have measurements, to do investigations with these people, with patients, to really understand also etiology of diseases. And having, in that sense, both the pillar and adding on the big data approaches is, in my opinion, the promising future.
There was a question behind you.
I just want to say that it was a very interesting discussion, but the problem for me is that when you said that big data are no hypothesis, and that when you discuss about the poor data that we have in the classical epidemiologic studies, I believe that the problem is that we don't identify the hypothesis, or we don't identify the goals to have some data. Okay, you have show a few examples of different type of data. One is surveillance of outbreaks. One is post-marketing pharmacological side effect. One is the other. And for all these type of things, we need to have some data, and we need to have a goal to have this data. You cannot have data and nothing and say it after, it could be this possibility. That is my view of this stuff.
And we all understand that we actually need some good data, no problem. And we all see that the opportunistic or whatever you want to say data are a reality. I would like, what would you tell then politicians, health planners, ministers of health, not only in Switzerland, how do we actually handle these tools? Not that one and the other has these or the other advantages or disadvantages, but I would like to get at solutions, get out of this plenary session at solutions on how we really have to reconcile the discussion. Because the important thing is, if we wait too long, these decision-making processes, not only in Switzerland, but in many countries go off track, because also we will lose also the chance to motivate, in Switzerland, for instance, to get these cohorts established. When people say, yeah, you don't need these cohorts, you could just go to Google and you find all the information. So actually, I would like to see how we, as a public health community, bring these elements together and have a strong argument to say, that's how we handle it. That's how we bring in these approaches into decision-making process. I'm very much adhering to thick data. Otherwise, I would not have invested also a lot of time in doing such data collections for a long time. But I've always seen that this way to decision-making is much quicker when people just have the Twitter platform and the other things. We see this ongoing right now already. So please, what are the solutions?
You have 2 comments.
Well, first of all, thank you very much for your very stimulating presentation and comments. I just would like to know your opinion about the open data issue. That is the fact that the big data from the multiple sources of information we do have should be made basically freely available for analysis done by everybody. This is a debate in healthcare. It's going on at the international level, the fact that administration running healthcare systems should be made available their administrative data. And I see potential and risk in that, because one thing I understood from your comment is that the big data may have a lot of potential, but they do have a lot of limitation as well, and they need very well skilled people to be analyzed, the people fully aware of their limitations, and to take up the provocation of the title, if there is something that is going to kill epidemiology, is not big data, but possibly open data. So I would like to hear a comment from you on that.
Another comment, and then we come back.
It's very interesting to link this discussion to decision making. And I think we can have a very long debate, and we should, on the complementary nature of both big and thick. The political decision maker could not care less about this discussion, however. They're interested in the so what of whatever information we supply. And I would recommend everyone to read a very good book. It's called The Honest Broker, and the author is Pielke, P-I-E-L-K-E, Pielke. And it has to do with tolerance with uncertainty. So when we come with big or thick data, if the only conclusion we can bring is that we don't really know, or the decision maker is uncomfortable with the conditional nature of data. And the notion of honest broker has to do with the so what, and from the data, our ability to generate plausible implications for immediate decision making. So I think that's the context for the decision making part of the discussion. So the honest broker.
Yes, thank you for all these questions. The room is very warm at this early session, and congratulations, all of you. First of all, I have to specify that I have not said no goal. I've said no hypothesis. It's not the same. You know, the astronomers in the 17th century just observed the universe, and they deduced from their observation the rotation of the stars, the model. So the model was deduced from observation. I think we have lost the sense of observation in epidemiology. I am really fond of descriptive epidemiology, but I can tell you that in our world, for our careers, it's much better to be an analytic epidemiologist than a descriptive epidemiologist. And I think it's a wrong way. I think the big data bring at least this this potential for a better observation of our societies, of our world. In that meaning, I think big data provides some interest in this question. The second point is open data is a very important issue. And if we can fight for a society with open data, of course there are some risks with open data, but we have seen with all these problems with the NSA and so on, that we have probably much more risk with closed data than with open data. So I think the open data issue is real important issues. And regarding the link with decision making, I think I would say the first step, and this is the two questions also that with Marcel, I think that was also with decision making, or at least with decision makers. I think the first step is training. Training. What we will need is competencies. I am not sure that we are training our public health professionals appropriately today, because if they cannot handle this data mining, this modeling, these statistical tools, as well as the non-quantitative tools, I mean, the public health scientists, and this is my way of understanding what we name global health, is something which is really interdisciplinary, which can handle the qualitative data and the quantitative data, not only one and not the others. But I think what we need is to have some competencies in the quantitative data, which are completely new for most of the epidemiologists. Handling big data today are really calling from new expertise, new competencies. And I'm almost sure that that will not be possible, even if we may agree that thick data will, of course, survive, but that will not be possible to run a pharmacovigilance department in the pharma industry or in any agency without having the skills of the data mining and the big data in board. So I think first of all, we have to reinforce our programs in public health and in epidemiology to include these competencies.
Hello. I want to have a comment, and I ask both of the opinions, your opinions. And I want to ask about big data and thick data in terms of involvement of the subjects or population in terms of providing the data. Because one of the things which were discussed here was the big data actually has no so qualitative input in like that you can get as thick data. But I think that like Google and like these social networks, these patient networks, that actually people are providing maybe more qualitative data actually that you can get with thick data approach. For example, also in this very well-planned researchers that you ask questions to the subjects, but subjects don't really freely also comment on the side effects or whatever that they had. And it's easier if you are sometimes not really subjectively known, like you just write something with another username. Maybe that's easier for the people to comment. And secondly, I think the big data, in terms of the subject's involvement, in terms of, like, you can write a Google research, okay, flu, and the flu goes, whatever, and then it's also, it can also prepare you to be part of the tech data, as if you have a cancer or whatever that you get, you go to these patient sites, and then you can see a new something is approaching, and then you can be part of a trial or something. I don't know what you think about it, the involvement of the subject in data.
Well, I mean, you refer to the question on how to collect the data. And of course, even in a thick data framework, you may choose other tools to actually secure anonymization in a different way. But still, I think the basis of addressing hypotheses is that we do know with which population we work and that we actually include all segments of the population. I mean, I referred a lot to poverty. There will be a huge selection if we just let our research be done based on those who are out there and ready to participate for whatever reason.
I would like to comment on the question how to deal with this in a political scale. I think today, potentially I see a bigger potential to use the big data and not the thick data, where we have some things that happen fast, like outbreaks or so, where velocity can really be an advantage of the big data. If we really think about public health issues and solutions, I also agree we need the thick data, the richness. So what to tell the politicians? I think really, if they think they can only live on Google, we really need to educate them with these examples, how wrong aggregated data can go. And the other thing is I would use that really to push the e-health agenda, because yes, we have more potential to analyze big data, and I mean, big data in the amount of really having many, many different data points. But if we don't feed them with the quality, the outcome will be poor. And the potential is there if we feed it with the right data, so I would really try to combine the two topics and push for the e-health and collecting better data.
Okay, a last word, because we have then to come
well,
to an end.
I think this is a great idea, and of course we should be very clear. Thick data does not mean old methods. Yeah? And of course, I mean, Swiss TPH moves very much in that direction. Thick data. So my vision would be that we have 100,000 Swiss people who are proud to be part of this long-term research. And they are part of their study, whatever, Facebook or whatever, and they are ready there actually to answer very fast questions that may pop up where we really want to know something relevant in an immediate way. We have not started in Sapalde to use those tools now, but I mean others do, and I think we should really not say it's either thick or e-health. I mean, the tools should be combined, and I'm very enthusiastic and optimistic because of our experience that we do have people are ready to participate. Participation rate is high. 95% of the Sapalde subjects completely agreed to give their DNA, all the genetics. I mean, if you do those things right, people are ready to participate, and even no matter what's going on in the big open domain where you may have scandals, you have a collection of people who are ready to participate, who have confirmed, have given consent, and they trust. I mean, that's of course, you build trust in the study that they belong to, and I think we should pursue that vision also for Switzerland.
Just a few words also, just to say that big data does not mean only funny and easy work. You may have read a paper in the New York Times last week, which says that the big data scientists say that they spend 80% of their time in cleaning the data, in cleaning the appropriate format, because they need, of course, to work ahead of the final analysis. So it's very close to what we are used to in epidemiology also. So now make this week funny for you and easy to learn.
Okay, I think we come to the end of this session. I think it's a very interesting debate, and you see that it's not clear-cut, white and black. And I think I very much liked also your last comment, because it's not true that big data is just easy and nice to work with. But I think we got a lot of interesting combinations and applications of both types of data, and it's true, it's a reality. And on the other hand, we also should be very innovative in using modern tools in classical epidemiology. I think we go now to the break, and afterwards to the courses start, and I thank you very much for your lively discussion and the contributions.
Thank you.